how to counsel a patient correctly for diagnostic tests. Depending upon the condition of the patient, if you have to prescribe a test that may be expensive, how do you correctly counsel the patient about why it's important and why they need to get it done? Dr. Somashela, what are your thoughts on this matter?
Right. So most of the time, let's say in cornea practice, many of the investigations we do sometimes are not very hardcore or really required to diagnose what is wrong with the patient, because we can examine on slit lamp. But on the other hand, in retina, you need a lot of investigations for the patient for us to reach a diagnosis and plan. So there is no other way. We have to explain to the patient that really you need these investigations for me to come up with the reasoning. And sometimes the tests can cost a lot. So if you add up a whole pile of tests, which they would need actually, so it depends if you're on your own practice or if you can afford the kind of a discount or something like that. That goes a long way, because you know that based on these tests, you're going to plan surgery for the patient. So if I have a patient who I know can afford only a little bit, then I'd rather that patient spends that money for surgery and I write off some of those diagnostic tests. So that can be possible if you have your own practice. But if you have to send the patient out for the diagnostic test, then you have to be very selective in what you need to send for. That I think is the best way to go about it.
Thank you, ma'am. Dr. Himanshu, sir, what are your thoughts on this matter?
Yeah, no, it is so very important. Every which is mentioned, the biggest ruckus is in the OPD when you given a patient an appointment for 4 o'clock, and somehow most patients don't realize that an ophthalmic examination takes 1 hour to 1.5 hours. So somewhere the receptionist tells them that you have to be prepared that this is going to take time. It's very very vital. And once one patient starts misbehaving in the OPD, 15 others wake up. The common answer. This is how the problem starts. And that is where one has to be very, very patient. One more thing that I wanted to mention was post-operatively, how Dr. Grover said that you have to be firm, but yet you have to be malleable. Something very important. We have had patients post-op doing very well, 20/20 N6 kind of, but dryness bothers them. And the moment you tell them that no, you have dryness, the first thing they'll come up with, how come I never had dryness before the surgery? So now the first thing that you've done, the surgery is for vision. They have forgotten about vision. And that sidetracking happens to something else altogether. So this is very important that at that time you don't take the onus and say sorry. What I would say is that, ma'am, your surgery is doing very well. It's absolutely fine. Your vision is very good. The purpose for which you came to me is just been served, and we have to go ahead and do that and tell them very firmly. Now, with respect to diagnostic tests, you have to be very clear with them that these are the tests, because ophthalmology, moment you tell them this test has to be done, and that test, you have to do an OCT, you have to do a perimetry, you have to do your topography, they just feel that we are postponing their inevitable diagnosis. And how come you cannot diagnose by looking at me on front face? You have invested a lot in these equipments. You're in those expensive equipments. You have spent time, money, energy on that learning. And here the patient feels by looking at their face, you'll be able to give a diagnosis. The common question Dr. Grover will tell you that in our OPD, in KEM, you ask a patient, आपको क्या तकलीफ है? आप डॉक्टर हैं, आपको सब मालूम है मुझे क्या होता है. Now, they are not even ready to answer your questions. What is it that they have trouble? So they find it very difficult at times for self that they have to undergo various tests before they come to a logical conclusion or a diagnostic. So when you have a few equipments with your own self, or you have to send them out for an MRI or a B scan or some scanning procedures, then it is very difficult, but you have to explain to them that technology has changed. We can see your retina better. All the 10 layers of your retina can be seen on a 3D. You can also see various aspects of your field of vision, your optic nerve, and make them understand with pictures. This is how, taking a picture, how often it is important that when you take a fundus photograph, if you just explain to them what is the optic nerve, what is the macula, they realize, oh my God, this is how beautiful it is. Taking a picture and you understanding, quite often they don't even understand why you take a picture. Topography is of no great use. But you tell them that topography which is done is like your drones, the US drones taking pictures of the Afghan terrain. Where are the terrorists hiding? You give them that kind of an example and tell them that, look, you do your topography to find out whether there's a hidden keratoconus or a form fruste. You don't want to mess up with your eyes. Give them a logical understanding, because they are averse. Again, in the society, most patients feel that doctors unnecessarily do tests. They don't realize that it is something very vital to their diagnostic criteria. So you have to make them understand. You can make a set of tests for, say, glaucoma, for retina, and make them understand and answer their queries and explain a little more in details. This is how they will get their faith, and tell them to preserve these records for the rest of their life. I hope that gives a little more answer to that.
Yes, sir. Thank you very much. Dr. Grover, sir, do you hold the same opinion? How do you think it is prudent to handle these situations if a patient feels that a diagnostic test is unnecessary?
And the earlier speak panelists have really covered up pretty much. Only thing I'll point out is that there is a sea change over the years that we have practiced. Dr. Himanshu will vouch for that. How over the last 30 years or 40 years, and there is a huge change. We used to just write the investigations which we thought were right, but now we have to give a lot of thought to what the patient thinks about it, because there is such a lack of trust which has developed over the years that you feel defensive about writing a genuine investigation, particularly if it is imaging, which is if it's an MRI, because in the popular mindset, they are so much associated with cuts and so on and so forth that you have become defensive in your writing. And therefore, I think, as everybody explained, it is vital to explain to the patient as to why he needs them, what his eye condition is, why this particular investigation is going to contribute to our understanding of the disease or its prognosis or the pathology, which will help us in making the right decisions for him. So that trust is the biggest word, which has become a casualty. I think it's up to you, the next generation, to build that trust again. I think there's no substitute to that. And possibly the COVID epidemic has helped a little, maybe 20% towards that direction of building back that medical professional dignity or medical professional respect. And you should all strive to rebuild that, because you want to do the best for the patient without the barrier of lack of trust. And that is one huge responsibility that you will have on your shoulders as you take over the responsibility of managing Indian ophthalmology.
Very true, sir. I hope that all of us as a generation can rise to this responsibility. Dr. Shreyas, sir, what do you think about diagnostic tests? What is their relevance?
I think most of it has been covered. One small thing which I find useful is having some sample images on your desktop or laptop, whichever you're using, and showing the patient, let's say if you're asking for an OCT or a topography or something, and you show them a sample of the disease which you're suspecting for them, and say that this is the image, and this is the reason why I want a topography for you. I think that helps them understand why the importance of the test, and usually that works. I mean, I'm still maybe Coimbatore is still 20 years behind Delhi, so patients still trust us at this point of time. But I'm sure all those issues which Grover sir just mentioned, I'm sure we'll face in a decade or so.
Okay, so thank you, sir. So, Dr. Gaurav, do you have any opinion on this matter?
I think we've already covered almost everything, but I understand that what Dr. Grover said, sir said, first of all, you have to, kind of have a reputation that, your practice is ethical, and you're probably, you have to build it over the years. If you have a habit of writing like 10 medicines and 5 tests for every patient, eventually patients will find out that, you are kind of trying to maybe overprescribe or, overprescribe tests and all. So you build that reputation over a long period, and it takes very little time to lose it. So first thing is win the trust of your patients, and that kind of travels. It carries forward, and patients come to you knowing that they are going to get ethical treatment, and so you have to live up to that. Number one. Number two, there are times when you actually need those, several tests. For example, if you were investigating a glaucoma patient and you want to see a field test, and then you want to do an OCT, you want to do a pachymetry, you want to do a gonioscopy, and the works, 5 things that you need to do, maybe a disc photo if you want to look at it. So obviously now patients may not understand. Patient just came to you for a routine exam. You saw a suspicious cup and you saw borderline pressures, and you wanted to investigate, and maybe a small family history as well. So I think, when you advise these tests, you can prioritize, and you can tell them, first of all, don't push them that you have to do everything today. I typically tell them that these are the few things required. If you want to do these today, you can do them. You can come back tomorrow, so that they don't feel that you're coming after them. Number one. Number two, you should be able to explain to them yourself, or a counselor can also do that a little bit. And you can tell by the look of the patient, the moment you tell them that, we might be doing a few tests, some patients will be happy to do because they're aware and they're alert, and they would readily agree to do those because they might have somebody in the family who's already been going through these tests. And there may be others who might feel that you're just advising them for no reason or whatever. You can tell from the look of the patient.
Yeah,
and then
I think that is very important.
Yeah. Right. So body language, and if you notice that the patient is not convinced by what you said, you have to be alert, and then while you don't have to go and sit around justifying everything that you do, because then it goes beyond the point of what you should be doing. But with some little bit of authority, you can tell them why you're doing it. For example, you can say that I need to do a field to check because glaucoma, you can have field losses. I want to check your optic nerve as well because that can show some changes. And I need to, be sure that your pressure. So they will understand. It just takes you a minute to explain. And I think beyond that, you can always we know some patients who cannot afford. So I might decide that, if I'm doing an OCT and a field and maybe they need a pachymetry and something else, I'll tell them, okay, to charge them for these 2 tests, and the other 2 you can kind of, do academic or whatever we call it as academic when you're not charging for it. So you can always help the patient. Patients feel very happy. You can kind of push in 1 or 2 tests free included in the package, or you can create a package which has, maybe for all those 5 things and, subsidize it and maybe charge just about 2,000 or 3,000 for the whole package of investigations. So you have to have something for all class of patients. You may have poor patients. You may have paying patients who don't mind paying for all the tests. And last thing I think here is that once you've got the test done, please be serious about explaining to them why you did the test and what came out of the test. Sometimes you will have the patient do all the tests and you will the patient comes back to you and you may not even see the patient and you may just hand the prescription with the medicine. Now, patient will think that you just got the test done for no reason and you didn't even bother to look at the test. You may have a field and an OCT report lying in the file and, maybe you didn't look at it and you just wrote a medicine thinking that, okay, I know what this is. So it's always great to just spend another minute when the patient comes back to you with all the reports. Once, that, okay, your field show this and your OCT, and so now our decision is justified and this is how you go about it. I think these few points can help build your credibility and patients then learn to respect what you're doing. And also, I think on every instance that they visit you, if you keep doing tests every time for the same thing, that's another thing which can probably put them off. So I think you have to develop a reputation of how you justify what you're doing. That's what it boils down to. I mean, I gave a long answer, but I don't know whether it made sense or not.
So very valuable points, I think, born out of true experience. And this is what we all use very much. If you have that distrusting look on the patient's face, which you can sense in that fraction of a second, I usually say, oh, you don't have to get them done today. Think about it. Get it done some other day. Come some other day and get it done. Because you give them time to digest it. And because if you are springing something on them, they never thought of glaucoma and you're telling them that you are a suspect and that you need these tests, tell them to do it at your leisure. There's no emergency about it, and so on and so forth, which brings that little confidence in them.
Thank you so much, sir. Dr. Rishi Swarup, do you have any closing thoughts on this matter?
I think most of the thoughts have been very well articulated by everyone. In fact, I was going to say what Shreyas said. Having a few sample images really helps. And if you can just show the patient that this is what a normalized test would look like, and this is what I'm suspecting in your eye, and this is what I'm looking for, I think that really goes to convince them often. And most of our scans and all now have it's not numeric. There's a lot of visual things you can see, like in OCT, you can see if there's a vitreomacular traction, you'll see a band going from the fovea. So you can show that this is what I'm looking for. Even for your cataracts, if you're premium cataracts, if you're doing an OCT prophylactically just as a pre-cataract evaluation, you can show them that sometimes you have these kind of lesions, and if you don't pick them up before surgery, you can have a suboptimal outcome, and this is the reason we're doing it. So if you just explain to them, most of the time patients will accept them. And like was very well said by Dr. Gaurav and Dr. Grover, there are some patients who are always untrusting, and you can make them out. And those patients, if you can avoid the test, I think it's best avoided, or you just write it off. If you want to do it for your academic purpose or to understand, you just write it off because you need to do it. But you know that this patient is going to not trust you. Sometimes you can just absorb that cost. In the larger scheme of things, it won't matter.